Okay, and I'll pass you over to Jadira and Dr. Miro, please. Welcome, Daisy, if you'd like to introduce our speaker.
Great, thank you so much. Hello, everyone. So it is a pleasure to introduce today our speaker of the month, Dr. Pamela Kunz. She's an associate professor of medicine in the Division of Oncology at Yale School of Medicine and director of the Center for Gastrointestinal at Yale Cancer Center and Smilow Cancer Hospital. She received her medical degree from the Dartmouth Geisel School of Medicine. Her postgraduate training includes a medical resident, chief resident, and oncology fellowship at Stanford University School of Medicine. There, she was the director of the Neuroendocrine Tumor Program, led the oncology research group, as well as the Neuroendocrine Tumor Fellowship. Dr. Kunz is an international leader in the treatment and clinical research of patients with gastrointestinal malignancies, as well as neuroendocrine tumors. She holds key leadership positions in the field, including the chair of the Neuroendocrine Tumor Task Force of the National Cancer Institute. She's now the current president of the North American Neuroendocrine Tumor Society. In addition, she has emerged as a leading voice for promoting gender equity in the medical workforce and served as a vice chief for diversity, inclusion, and equity for the section of medical oncology at Yale. She was recently awarded the Women Oncologist of the Year by Women's Leaders of Oncology. Beyond all of the compliments that she has achieved, and of course, a real model for me and for many others in the field, one of her goals is to also bend the field of neuroendocrine tumors treatments through clinical trials as well as translational effort to then develop the next generation of treatments for neuroendocrine tumors. Without further ado, I would like to welcome Dr. Kunz today. Thank you so much for accepting our invitation.
Thank you, Dr. Del Rivero. So I'm really pleased to be here. That was a lovely intro. I will share screen, so bear with me for one moment. How's that? Okay, all right, excellent. Good. Well, I was talking a little bit with Heidi about sort of the audience. I've not met with you guys before, and so I know this is a net savvy group, so I am not going to do really much in the way of basics. I'm really going to focus on clinical trials, and then I'll kind of give a little brief outline, but I thought it'd be fun to include some of the new data from ASCO and Esmo. So these are my disclosures. Let me go back to that line for just a minute. So I'm going to kind of give maybe 3 or 4 slides just on like the current state of NETs, just to provide a framework for talking about the rest of the new data. We'll focus on some key studies from the ASCO and Esmo meetings. The Esmo meeting was just last week. I'll talk about some of my favorite ongoing studies. And then as Heidi knows, I like to really talk about equity and what it has to do with science. And I've really made a personal commitment to talk about that in all of my presentations. So this is a timeline of really just the incredible advances we've had in the last decade, and you can see them all really clustered after 2011. And it's been an exciting time. I sort of finished my fellowship around 2008, and I went into the field of NETs. I had a mentor who said it's easier to become an expert in a rare disease. And at the time, very little was known. And it's been really an amazing journey to be part of some of these clinical trials and the clinical research and really this whole community. So the current treatment algorithm, and I'm going to just focus for this slide on well-differentiated GEP-NETs. This is adapted from the NCCN guidelines. So you guys all know this, but really first line is octreotide or lanreotide for the most part. For pancreatic NETs, if there is disease progression, we have all these options. So we have everolimus, sunitinib, cape-tem, ludotatate if SSTR positive, other cytotoxic chemo, liver-directed therapy, or clinical trials. For small bowel nets, we have really some of the same everolimus and ludiditate overlap. Also clinical trials, liver-directed therapy, and less often we'll use cytotoxic chemotherapy in small bowel nets. But what you'll also notice here, and really I think a gap in the field, is an ability to really tell patients what the optimal sequence of therapies is. And that's, I think, an opportunity for us. We'll talk a little bit about some clinical trials that are trying to answer that. I'd like to mention a couple of, this is, I think, a really important paper that's just come out this year on the updated 2022 WHO classification. This is an attempt, and I know the font is small, but happy to, I think I have the reference listed here and happy to share this with Dr. Del Rivero after. As many of you know, the NET nomenclature is incredibly confusing and really over the last many decades has evolved, and we still have some leftover terminology. There are many ICD codes when we try to do epidemiologic research. And there has been an effort in the last couple of years to try to harmonize the language around NETs across site. This is, I think, one of the first efforts I've seen that puts this, the manuscript is actually beautiful. So if you have not read this yet, I highly recommend it. So up here are the GI and pancreatic nets. This has not really changed. Many of you know that the last iteration in 2020 had NET grade 3 as a new add. That has not changed. What I've put here in red is a new category for the upper aerodigestive tract and salivary gland. So that's really the esophagus. So we now have nomenclature around that. It really mirrors the lung NET guidelines. You'll see that NET grade 2 has a mitotic index of 2 to 10. And as long as the KI 67 is less than 20, they also still include the well-differentiated NET grade 3. So that is new. The other really key thing that I am really happy to see, I've really wanted to get rid of typical and atypical in the lung NET in terms of the nomenclature, but they have finally added grade 1 and grade 2 to try to, again, harmonize some of this language. So happy to see some of these changes. The imaging advances, many of you are aware of, but what you may not know is that the first somatostatin receptor-based imaging was with iodine 123 labeled octreotide, and that was published in the 1980s with some familiar names like Dr. Krenning. And since then, we've seen 4 FDA-approved somatostatin receptor-based imaging. The first was Octreoscan in 1994. The second was gallium-68 dotatate PET in 2016, then DOTA-TOC PET, and copper-64 dotatate PET, those last two in 2020. And I would say in general, the most widely used is the gallium-68 DOTA PET, but copper-64 is being used a little bit more often. The half-life of copper-64 is longer, therefore it's actually a little bit more practical for hospitals and medical facilities to have that agent. It can sit on a shelf for a little bit longer. There is also a handy guideline that gets updated every couple of years on somatostatin receptor PET appropriate use criteria. We reference this sometimes when we have to do peer-to-peer approvals for insurance companies. And most of our imaging, this is just as a side note, most of our imaging tools now actually require appropriate use criteria in the US for Medicare. Okay, so let's move to talking about some of the key updates from ASCO and Esmo. So I selected oral abstracts, which really, for those of you who are not medical professionals, are really considered the potentially most impactful or often larger randomized clinical trials. So I had the personal opportunity of presenting the final results of the ECOG-ACRIN 2211 clinical trial. So this was the randomized study of temozolomide or temozolomide and capecitabine in patients with advanced pancreatic nets. I'll remind you that this is a randomized 1-to-1 study of temozolomide at 200 milligrams per meter squared daily, days 1 through 5, or the combination of capecitabine, temozolomide. Those pills are taken over a 2-week period. And then patients would have 2 weeks off. So the total cycle length for both arms was 28 days. The primary endpoint was progression-free survival. This data was presented actually back in 2018 when we found that the study met its primary endpoint. The median progression-free survival in the combination arm, that's in yellow, is longer at 22.7 months compared to about 14 months for temozolomide alone. This was statistically significant in terms of the difference. And I would say clinically meaningful difference as well. This is the new data that we presented at ASCO this year. So we presented the overall survival data, and there was a trend towards improved overall survival, but it did not reach statistical significance. This is very common for NET studies, as many of you know. Patients with indolent disease go on often to get many subsequent therapies after the clinical trial agent. So you can see that the combination arm was longer at 58.7 months versus 53.8 months. And I would argue that that's a clinically significant difference, but it did not meet statistical significance. Another key takeaway is that objective responses were really high in both arms. The study was not designed to detect a statistical significance in response rate, so that p-value, as you can see, is not significant. The response was 40% in the combination arm and 34% in the temozolomide alone arm. The other new finding, which I think is a really important contribution, is MGMT. So I'm going to just define this for the group. So MGMT is methylguanine methyltransferase. It's a DNA repair enzyme. There is some data in brain cancer, so in glioblastoma, that when this DNA repair enzyme is deficient or low, that predicts response to temozolomide. So wouldn't it be great if we had better predictors of response? Well, we couldn't exactly test that in this trial because both arms contained temozolomide, but we did look to see if MGMT deficiency was associated with response. We tested that in 2 ways, with immunohistochemistry, so that's looking at protein expression, and we also looked at MGMT by promoter methylation. So MGMT is considered deficient if it's low, has low protein expression, or if the promoter is methylated, or that's positive in the column. So the red boxes are drawn around the deficient, the MGMT deficient patients, or the patients with MGMT deficiency. And then the bold red font indicates patients with an objective response. And the response rate in patients whose tumors had low IHC expression was 52%, whereas those whose tumors had high IHC expression was 15%. So you can see really associated with what's in the red box. The same pattern we see for promoter methylation. 85% of patients with positive promoter methylation had objective responses, compared to 38% who did not have promoter methylation. This is really the first time in a prospective study that we've examined this. The other interesting thing is that all patients with promoter methylation were also IHC low. So that really, you could see that best in the Venn diagram. And this really suggests that MGMT by promoter methylation is not sufficient as a biomarker for pancreatic NETs, and that other mechanisms of MGMT downregulation are likely involved. So we have I will say, stay tuned. We have our manuscript actually that should be coming out within the next couple of weeks in JCO. So the other NETs actually got 2 oral abstracts this year at ASCO, which was very exciting. And the second was a study that was done in the UK. This is NET-02. And this was a multi-center study, phase 2 randomized trial of liposomal irinotecan and 5-FU, that's called sort of Naliuri and 5-FU, or docetaxel in the second-line setting for patients with progressive, poorly differentiated extrapulmonary neuroendocrine carcinomas. So long title, but really it's the high-grade lung neuroendocrine carcinomas, or extrapulmonary, I should say. The study design here, patients were randomized 1-to-1 to receive one of those 2 regimens. So irinotecan plus 5-FU or docetaxel. 100 patients were planned. And the primary endpoint was the 6-month progression-free survival rate. So I'll remind you that this population has a more a worse prognosis, so therefore their PFS and overall survival will be lower. So this met the primary endpoint, so the required level of efficacy. So just to help you look through this, this figure here, liposomal irinotecan is on the left, docetaxel is on the right. The y-axis shows the percent, that's the PFS rate, and so it met the required level of efficacy for the liposomal irinotecan arm, which did better. That 6-month PFS rate was 31% in that arm, compared to 13.8% in the docetaxel arm. The secondary endpoint was response rate, and it was about the same between the two arms at 10%. And then the secondary endpoint, another secondary endpoint was overall survival. The median overall survival was longer in the liposomal irinotecan arm compared to docetaxel, 9 months versus 5 months. So the conclusions here are that the liposomal 5-FU arm met the primary endpoint. The objective response rate was similar. And I think that this really, we often there really has not been prospective data to inform our decisions in the second line setting after carboplatin etoposide on what to do. I often kind of weigh deciding between an irinotecan based regimen and a taxane. So I think this is an important prospective study. All right, on to Esmo. So I did not personally attend Esmo, but I was able to pull some of the abstracts. And there were actually 3 oral abstracts at Esmo on neuroendocrine tumors with randomized studies. So exciting to present that. The first is the Sector trial. It's a randomized phase 3 study. And I had mentioned earlier that we might start seeing trials that look at sequence of therapies. And this is really the first that's doing that. We've been awaiting these results for quite a while. So this is looking at the safety of everolimus followed by chemotherapy, or the reverse, chemotherapy followed by everolimus. The chemotherapy that they put in this is streptozocin and 5-FU. So one could argue that certainly in the US, we don't use a lot of streptozocin 5-FU anymore. Cape-10 has really replaced that. But I think regardless, this is an important study nonetheless. So the study design, as I've mentioned, arm A, everolimus followed by streptozocin 5-FU, and then arm B was streptozocin 5-FU followed by everolimus. The primary endpoint actually had to get changed because of slow recruitment. So it is the PFS to first treatment, or PFS1. So that's a slightly kind of different or novel endpoint than many of our other studies use. The progression-free survival 1 was in arm A, 21.5 versus arm B, which is 23.6. And so the primary endpoint really was similar. There was not a statistically significant difference. You can see that with the p-value of 0.3. Objective response rates were also slightly improved in the streptozocin 5-FU arm. I'll read you just kind of the top line here. The objective response rate overall in the streptozocin 5-FU arm was 21% compared to 8% for everolimus. And I think that's not surprising. Most of us know that everolimus is a cytostatic agent and doesn't generally yield significant tumor shrinkage. So the authors concluded that both sequential strategies showed similar efficacy. I think this actually reinforces current practice. Most of us say to patients, you will likely get all of these agents that we have in our toolbox for patients with pancreatic NETs. It doesn't reinforce giving one over the other necessarily. However, if you have patients that really are in need of an objective response, the cytotoxic chemotherapy may be a better one to start with. And we know that from capecitabine temozolomide as well. Okay, the second Esmo study, I'm just going to check I'm doing okay on time. So this is a multicentric randomized phase 2 trial comparing lutetium dotatate in unresectable progressive neuroendocrine pancreatic tumors, and it is comparing it to sunitinib. So this was a study that was randomized 1-to-1 for patients who receive ludotatate versus sunitinib or Sutent. Again, I think what's really exciting, we have for the last decade had a number of advances that have led to new FDA approvals, but we have not, and most of those FDA approvals were comparing investigational drug versus octreotide or investigational drug versus placebo. So we are starting now finally to see clinical trials that demonstrate really comparing to active agents, which I think is really our next round of how we advance the field. And so the primary endpoint for this study was looking at progression-free survival at 12 months. What's shown in this table is the patients from just the ludotatate arm. So there was an 80% progression-free survival rate at 12 months, which is actually quite high. When we are comparing progression-free survival of the two arms, which is really a kind of standard way of looking at it, we can see that the progression-free survival was 20.7 months in the ludotatate arm versus 11 months in the sunitinib arm. So this is really, as I'd said, the first randomized trial to compare ludotatate to another active agent. Ludotatate was associated with a longer 12-month progression-free survival. There were no new safety concerns. They did not show that data. And I think that, the authors suggest that this could be practice changing. This didn't specifically test sequence of ludotatate prior to sunitinib. It was really comparing them head to head. But I think that there are some, I will talk about some of these other studies, Compete and Compose, that are also additional head-to-head studies of ludotatate versus other agents. But I think it's really, we are always cautioned against doing cross-trial comparisons. So I think it's very helpful to have these data. All right, the third Esmo study is looking at bevacizumab plus FOLFIRI after failure of platinum etoposide in patients with advanced neuroendocrine carcinomas. So again, this is really asking that question of what should be using the second line setting, like that other study that looked at Nal-ERI versus docetaxel from ASCO. This was a study randomizing patients with advanced refractory gastroenteropancreatic an unknown primary neuroendocrine carcinoma. So 1-to-1 to receive FOLFIRI. So this is another 5-FU irinotecan. So that's slightly different than the Nal-ERI, but really in the same class. This adds bevacizumab versus FOLFIRI. And the primary endpoint was more than 50% of patients alive at 6 months in the experimental arm. And you can see that here, there was really not a significant difference between the two arms in terms of overall survival. So, except they are, sorry, I'm like misspeaking. They said, well, I guess the question is it clinically meaningful? It was statistically significant difference when they looked at the 6-month difference. So 58 versus 52, that yielded, in reality, a 1.9 month difference in overall survival. So it reached its primary endpoint, but they're saying that the addition doesn't seem sufficient to be explored in a comparative phase 3 study. And so I think really looking at, is it clinically meaningful difference? Having, however, this data, I think, is what they're making in their third bullet point there, is that the FOLFIRI regimen has the highest level of evidence after first-line platinum etoposide chemotherapy. I think, again, this is an important contribution to the literature regardless. Okay, so let's talk in the sort of second half of the presentation where we are headed with ongoing studies and what questions we're hoping to answer. So we know that NETs are a chronic cancer. Patients live for many years. SSTRs are a unique target for imaging and treatment. Somatic mutations are rare in general in the low-grade NET population, and tumor mutation burden is generally low. And germline mutations are actually more common than once appreciated, can be up to 15%. And existing biomarkers are imperfect. We talked about MGMT as a potential biomarker. We haven't proven that yet, but it's provocative. Our treatments, we have many, so somatostatin analogs, mTOR inhibitors, VEGF pathway inhibitors. So the mTOR inhibitors include everolimus. We have VEGF pathway inhibitors like sunitinib. They yield stability. CAPE-TEM, I would add here 5-FU-streptozocin and ludotatate slow progression and also shrink tumors. And the optimal sequence of therapies is unknown. And as I said earlier, that's a big gap. And most of our patients receive many therapies and thus experience years of toxicity. And I think as we examine survivorship issues in patients with NETs, that's something we also need to think about. So what are some key clinical and translational questions? I think having had the opportunity to chair the NCI NET task force, I'll remind everyone here, this is really how we think about the priorities of clinical trial development in the US National Clinical Trial Network system. So these are our federally funded clinical trials. We have really focused on thinking about treatment in the era of PRRT. I'll talk about that in a moment, but I think this is a really key question. How can we optimize it? Can we make it more safe? Can we make it more effective? Can we combine it with things? How can we take better advantage of the somatostatin receptor? If this is a unique target on NETs, I think this is a real opportunity. And can we identify resistance mechanisms for all of our therapies? And then we need better predictive and prognostic biomarkers. So we had the opportunity to host a NCI NET clinical trial planning meeting. I co-chaired this with colleagues of mine, Dr. Tom Hope, who many of you may know is a nuclear medicine specialist at UCSF, and Dr. Simran Singh, who is a medical oncologist in Canada. And we actually, this was originally supposed to be in March of 2020, but we all know what happened then. And we delayed it a year, and then the world was still shut down, so we held it virtually. And we brought together a multidisciplinary team it was probably close to 50 or so participants from the federal government, from academic institutions. It included patients, med-onc, surgical oncologists, translational basic scientists. It was really all stakeholders who had expertise in NETs. The goal was to talk about how we thought about the next steps of treatment with this really practice-changing PRRT that was FDA approved in 2018. The executive summary of that meeting is posted to the NCI website. We have a white paper that is really a summary of that meeting that has been submitted. And we have our first clinical trial that was approved by the GI Steering Committee in a protocol in development that I'll mention. So the purpose of these clinical trial planning meetings is really to develop clinical trials. We also developed 4 working groups out of this. We're looking at DNA damage repair in PRRT. We are looking at dosimetry in PRRT, immunotherapy in PRRT, and liver-directed therapy in PRRT. And these working groups are still ongoing. We really thought a lot about, in the course of this meeting, the clinical trial planning meeting, of what was our current landscape at the time, how did we have to think about that landscape in the context of developing other clinical trials. This slide just really represents how we thought about that, and then how we thought about proposing other trials that would fill in the gaps. So we focused on many of our efforts on GEP-NET. And this is the first trial that has been approved and will hopefully open somewhere, if you live in the US, somewhere near you. So it is called NET Retreat, and it is a phase 2 trial of ludotatate retreatment versus everolimus in advanced small bowel NET. This takes patients who have already previously had ludotatate. They have to have had a kind of a durable response of 12 months, so a progression-free survival of 12 months prior to getting randomized. And at time of progression, they get randomized to 2 additional cycles of ludotatate or everolimus. So this question of retreatment, I think, is a very practical question. It comes up a lot in my own practice. And there are a couple of other studies that are examining this in slightly different ways, but this is the one that we're putting forward from the NCTN. I'll just give you a list of our open and pending NCTN neuroendocrine neoplasm trials. We've been really busy over the last few years. So we've had 6 new trials open since 2020. So I'm really proud of this group that's put forward all of these. What it means is that it's a really busy space, and I think we have to be, it's a little different than it was 10 years ago when we didn't have therapies. And now we have to be really thoughtful about carving out niches for clinical trials so that we don't compete with ourselves, basically. So this first trial, many of you are familiar with this. This is the CABINET clinical trial led by Dr. Jennifer Chan. It's a cabozantinib versus placebo. This is actually really, this is a little bit, I think I updated this a couple months ago there, so the accrual numbers are probably a little bit higher. The second, our own Dr. Del Rivero is helping lead this with Dr. Kim Perez. So this is a randomized phase 2 study in paraganglioma and pheochromocytoma of temozolomide plus or minus olaparib. You know what I might do? I actually have the schemas on the subsequent slide, so let's spend a few moments on that. So this was the cabozantinib study that I already mentioned. I'm going to do this one since we'll talk about this. So this is the Paraganglioma Fio Study. So 76 patients get randomized 2-to-1 to receive either temozolomide and olaparib or temozolomide alone, with a primary objective of progression-free survival. So really exciting that this is serving a really unmet need in this population. This study is another NCTN study that's a randomized phase 2 trial of ludotatate versus everolimus in well-differentiated lung net. So again, really trying to do more of comparing 2 active agents. This is being led by Drs. Hope and Dr. Pata. The primary endpoint is progression-free survival. And lung net in particular, I think, is an area that we need to dedicate more of our clinical trial space. This is another really practical question, is what do we do in the postoperative setting for patients with pancreatic nets that are high risk of recurrence? We have no data in this space, and so this is a randomized study taking patients with certain high risk features like size, lymph node status, Ki-67, randomizing them to either receive capecitabine temozolomide for 4 months or observation. And then another study that is just recently open is looking at neuroendocrine carcinomas, specifically looking at immunotherapy. And I think this is also a really important question. We have data in small cell lung cancer, but we don't know if we can extrapolate that to the extrapulmonary small cell. So this is looking at atezolizumab plus platinum etoposide, followed by maintenance atezo, and then atezo plus platinum etoposide followed by observation versus platinum etoposide. And it's a 1-to-1-to-1 randomization. And this is led by Drs. Chen, Dr. David Chen, and Dr. Gabby Churian. And then lastly, this is the 6th of the open trials. This is not quite open yet, but should be soon. It's a randomized phase 2 study of ludotatate versus CAP-TEM in well-differentiated pancreatic nets. So I will, just to editorialize a little bit, really excited to see that CAP-TEM, which has been my passion, has made it into 2 of these trials, one in the adjuvant setting and one now really comparing head-to-head against ludotatate in pancreatic nets. These are a few select trials outside of the US National Clinical Trial Network that I think will be impactful. 3 of them have closed and are, meaning they've met their accrual goals and we're awaiting results. So the RET-NET trial is looking at 2 forms of liver embolization, bland versus lipodiol. NETTER-2, hot off the press, met its accrual goal yesterday. So we will await results. There is a retreatment extension phase of that arm that won't be for new patients, but for existing patients at the time of progression, they can get 2 cycles of retreatment for NETTER-2. And I'll remind everybody, this was a first-line study looking at slightly higher Ki-67 of 10 to 55%. And the COMPETE clinical trial, also a randomized phase 3, is grade 1 and 2 GEP-NET, and that's lu-edotrietide versus everolimus. So all three of those, the top three, are closed and waiting results. The bottom two are still open. The COMPOSE trial is a randomized phase 2 of well-differentiated grade 2/3 metastatic GEP-NET, and it's lu-etitrotide versus investigator's choice of either everolimus, CAPTEM, or FOLFOX. And the last one is another Fio study looking at ludotatide. It's a single arm study, but I wanted to mention that just because I get asked frequently, and I'm sure Dr. Del Rivero does too, about the efficacy or utility of ludotatide in Fio. I'd like to also mention, I think, as I think I listed earlier, I'm really excited about thinking about somatostatin receptors as the perfect target. I think they're neglected as a target as we think about the traditional definition of targeted therapies. But there have been 4 studies really thinking of novel ways to target somatostatin receptors. So the first is lutetium saderatide. That's a somatostatin receptor antagonist. There was a small phase 1 clinical trial that looked at this. It had promising response rates, but it had pretty high hematologic toxicities that led to some dose reduction. So we're eager to see if that moves forward. PEN-221 is a peptide drug conjugate. So basically linking a protein and a kind of cytotoxic chemotherapy. This is another way that we can, that peptide brings the drug itself to the somatostatin receptor. This was a phase 2 trial that showed a high disease control rate or stable disease rate at 88%, but there were no partial responses. And it was pretty well tolerated. Tidutamab is a somatostatin receptor 2 CD3 bispecific antibody. This was also studied in a phase 1 trial. Those results were published last year. And there was a 55% stable disease rate, also no responses. So we'll have to see if that moves forward. And then lead-dotamtate, this was a kind of early results or preliminary results presented on the first alpha emitter PRT. Alpha emitter therapy has gotten sort of lots of hype, and there I think will be some other upcoming studies launching. Really eager to see where that goes. Alpha emitters, for those of you who are not familiar, are thought to, they have a shorter path length. So perhaps that would mean and indicate less toxicity and a higher energy level. So may be more effective, but I think we need the studies. I am going to end with the last few slides, just talking about what does equity have to do with the science of oncology. And kind of another hat that I wear, as Dr. Del Rivero mentioned, is really advocating for gender equity in medicine and broadly advocating for workforce diversity, equity, and inclusion. And I really like to think that as we try to diversify our medical workforce, that we will have more innovative science, and that will actually improve patient health equity. So that's the way I conceptualize this. So I really think it has to do with everything we're doing. And so I want to give you some examples of things that I've done, because I want to challenge every one of you, patients on the call included, that we should be looking through the lens of equity in everything that we're doing. So in my role as leading the NCI Neuroendocrine Tumor Task Force, I partnered with Dr. Karen Goodman. She is one of the co-chairs of the GI Steering Committee, which is the governing body over all of the GI task forces in the NCI. She's a radiation oncologist. And we decided, in fact, in the world of GI oncology, under which NETS generally lives, there are huge disparities in the number of in terms of female representation on PIs and authors and those on steering committees, et cetera. So we brought together a multidisciplinary group from the 4 National Clinical Trial Network groups and the Canadian group to really examine diversity broadly across these groups, authorship, who's leading the trials, who's sitting on the various committees. And we developed a mission statement and defined metrics. And in the course of this, the NCI, lo and behold, said, help us figure out identify opportunities and priorities to promote equity and social justice in the cancer research workforce. So you can see my cursor, that's sort of up here. So they put out this request for information. It was just seeking input from stakeholders. So we responded to it. It was a formal response. And in response, the National Cancer Institute Equity Inclusion Program, the EIP, formed a subcommittee to better understand and make recommendations to improve the representation of women and underrepresented groups. So really excited about this. Is an ongoing effort, but essentially all 5 of the NCTN groups will be surveyed to examine practices to make sure that they are equitable, inclusive, and promote diversity. We will identify benchmarks and then ways we can do better. Another example is I'm really excited to share. I was just awarded a new grant this summer. I am trying to personally look through this lens of equity in my own neuroendocrine tumor research. So there are a few retrospective studies that suggest that female patients have higher risk of toxicity to certain therapies, specifically CAPE-TEM, some of the VEGF agents, also Lutathera. So I have 3 aims in this grant. I'm going to examine the sex differences in outcomes and toxicities in a large database. Secondly, I will examine clinical trial efficacy, outcomes and toxicities within 4 completed NCTN neuroendocrine tumor clinical trials. And then the third is a prospective study to look at toxicity by sex and single nucleotide polymorphism, so changes in the DNA of patients receiving CAPE-TEM or ludotate. So I'm really excited about this new project. And then lastly, I have a new paper that's out this week, which I hope you will consider reading. We're trying to advocate for a culture of an inclusion and respect really throughout the culture of medicine. So again, I hope that we can all together look through this lens of equity in everything that we're doing in terms of how we collect data, how we hire, how we foster a respectful workplace and educate, how we develop systems of accountability, and then the research that we're doing. So in conclusion, NETs, as you all know, are not that rare, and they're deserving of high quality, basic, translational, and clinical research efforts. We have many therapies, many tools in our toolbox. PRT certainly has been a game changer. I think it's really framing how we ask future questions. We want to optimize patient selection, minimize toxicities, and increase efficacy. Multidisciplinary care and team science is critical in this disease. And I believe strongly that diversity of thought will translate into novel, innovative, and impactful science. So thank you for your time today. I will stop share. I'm happy to take questions and hear some reflections from you all.
Yes. That's wonderful, Dr. Kunz. It was really an inspirational talk to go over all the clinical trials and all the efforts that you're doing in diversity and inclusion and equity. I think we feel like the future is bright having a leader like yourself, trying to establish all of the difference and how we can help and unite and make a better future together. I do have a question. I don't know if any of you have a question, but I do have a questions about the MGMT by immunohistochemistry. And the question that I have is, what are your thoughts about doing MGMT by immunohistochemistry prior to starting capecitabine and temozolomide to determine who may respond or not, especially for those patients that we're using in the new adjuvant setting? What will be your thoughts about that?
Yeah, such a good question. And sorry, I didn't mention that then. I was like cutting down all my slides to try to fit within the time. So our takeaway sort of as co-authors from as our publication comes out, the way we have framed it is we've said MGMT is not ready for routine testing for all patients. But the caveat is that if you have a patient where the primary goal is response, we would probably recommend doing the testing. I think that IHC is probably the right test. I don't know that the antibody has been completely optimized. So that's actually a project that I'm going to be working on with a team at Yale. Would welcome feedback on that. I think that promoter methylation, as I said, is not the whole story. We need to learn what else silences MGMT.
Yeah, that's great. Anybody else in the group have a question?
I might have a follow-up regarding the MGMT since you gave this little teaser for your upcoming story. So I thought I hang in there. So I was wondering, I mean, there is a discussion about promoter methylation and the protein expression. And so do you think is it the catalytic function of MGMT that actually impacts the drug response, or do you think it's just an epigenetic setup which can be found in the tumors that have a hypermethylation in the promoters? Can you maybe follow up on that a bit?
It is an excellent question. I don't know if anyone else here has ideas, but I also think that this is, so I'm collaborating, I'll give you some hints on people I'm collaborating with. I think it's not been well studied in NETs. I think there are some really strong science teams I'm collaborating with at Yale, for example, who do glioblastoma research and are really wise in the ways of MGMT. And I think I'm trying to borrow some of the methodology that they've used in GBM to look at some of these questions. I don't think we know yet. It's a really good question, though.
And Dr. Simon, do you mind introducing yourself?
Yeah, that'd be great.
So I know that you're a scientist. I believe you work with Dr. Lines, right, Dr. Simon? Dr. Simon? Can you hear us? I don't know, Dr. Simon, can you hear us? I mean, Simon AM. I'm sorry, I don't know your last name.
Sorry. Yeah, I was not sure if there's. Yes, no, I'm working in the Institute of Pathology in Bern, Switzerland, in the group of oral parents. So we're coming from the epigenetic part or side. So, but not specifically interested in MGMT promoter methylation, but yeah.
That's great.
Yeah. Anybody else has any question in the group?
Dr. Kunz, hey, thanks. That was really awesome.
Nice to see you again. Yes.
It's great to see you too. Yeah. Yeah. Thanks for the great summary of everything from ASCO and Esmo. Obviously, to premier meetings that a lot of us couldn't attend. I was interested in your outlook on the lutetium dotatate retreatment trial. I don't know if you've gotten any of the preliminary looks at that data, but I was just interested as to perhaps what your expert outlook was on that. I guess, oftentimes we have this theory of, bottleneck events. If we attack everything that has somatostatin receptor expression, and then we expect to go back and be able to, recapitulate that durable response that we saw originally. I guess, what is your thinking on that? And do you have a generally positive outlook from any clinical data?
So we don't have any clinical data yet. But I will say, anecdotally, many of us have been doing this for a while. And actually, I will look to some of my European colleagues who've been doing it for a long time, but without prospective data to really guide us. I will just make a couple comments on this. I think there is, the question is, what's the right number of treatments for ludotatate? It's a fixed dose, as you all know, and I think that then that also raises the question of, should we be doing a better job with dosimetry? That's an active area of research and was one of our working groups from the NET clinical trial planning meeting. I think also our patients, many live for a long time, and I think many have already had alkylating agents in the form of temozolomide. I think there is a kind of real concern around development of myelodysplastic syndrome as we add additional cycles of PRRT and or sequence that with alkylating agents. And I think we need more data around who may be at risk for that. There was a trial, the ControlNet trial, some of you may be familiar with, out of Australia, combined alkylators with PRRT, and there was about an 8% risk of MDS, which is higher than the 3% risk quoted with PRRT alone. So we just have lots of unanswered questions, I'd say specifically around safety. There are lots of other experts on this call. I don't know if Heidi, if you have any other comments on that.
Yeah, I mean, that's you covered everything, Dr. Kunz. I completely agree with you. Yep.
Thank you.
And anybody else have any questions? I do have one question. If nobody else has a question.
I have a follow-up question about the retreat trial. Dr. Kunz, thank you for an excellent presentation. I'm just curious about the NET retreat trial. I see that, does it exclude non-functional NET or include?
I have to double check, but here, I can pull back or I can look at my own slides. Let me just answer that question, Lisa, 1 second. It's not open yet, so I have to hold on, and I can screen share with everybody. Bear with me and I'll.
And so people who have been previously treated with everolimus, I'm assuming they would be also excluded?
Let's see, so we'll pull this up. So right, so patients who've had prior everolimus would be excluded. And I think part of the reason that, so you're right here, so here are the key inclusion exclusion. And this, I have to be honest, that sometimes as a trial is going through the process of protocol writing and development, some of these key inclusion and exclusion get modified. This is not open yet, so this is this may not be the final version. So that's my caveat. The original intent of excluding non-functional NETs is that, as you may know, everolimus is officially in the RADIANT studies excluded non-functional. I'd say in practice, many of us still use everolimus regardless, but I think that may be why it was done.
Okay, thank you.
Yep.
Right. Awesome, Dr. Simon. Sorry if I'm not.
Yeah, I have a question regarding the proliferation indices and your experience in regard to CAP-TEM or TEM treatment alone. So, was there anything that you could add from your current study regarding that aspect?
The ECOG study of TEM versus CAP-TEM only included Ki-67 less than 20%. So it was really intended for the well-differentiated population that was specifically grade 1 and 2. That study was designed before the WHO 2020 criteria that defined well-diff grade 3. I will say that, and I actually probably should have included this. Some of you may know Dr. Jennifer Eads led a study of platinum etoposide versus CAP-TEM for high-grade neuroendocrine tumors. That was a negative study. So it appears as if in some of these higher grade that CAP-TEM did not beat. We were hopeful that it would maybe be better than, but there was really no difference. So so that was officially a negative study, but they actually in that collected extensive histologic information around grade and mitotic index, and we'll be reporting out on that pretty soon.
That's cool. If I may ask one last question, and also for Ms. Robinson, that way she can say the closing remarks. And thank you so much. That has been wonderful. And we used the whole hour, so this is great. So one question I have is for the data that you showed in terms of streptozotocin and 5-FU, because here in the United States, we don't use that. I think the Europeans use it a lot more. But if the goal is response rate, and especially with pancreas neuroendocrine tumors that had no response on gemcitabine temozolomide, would you recommend giving 5-FU and streptozotocin?
That's a great question. I think because streptozotocin and temozolomide are both alkylating agents, I would probably switch to a different class of therapy. So this is, again, an unmet need. So if you have a patient with a pancreatic NET who has really bulky tumors but's progressing on CAP-10, what do you use? I often will use FOLFOX. FOLFIRINOX is something that I also consider using, because we're then thinking about using, a platinum as opposed to sticking with another alkylating agent.
That's great. Thank you. Thank you so much, Dr. Kunz.
Thank you for inviting me.
I don't know if Ms. Robinson wants to say any closing remarks.
Well, only thank you very much for giving up your time. And thank you everyone for attending. Really great turnout today, all down to Dr. Kunz. And also just to let everyone know that October's Netchatter we will not be having, as it clashes with NANETS, which we don't want to do. So we are having a special Netchatter on Net Cancer Day on the 10th of November, where we are focusing on patient stories. So details to follow. But thank you very much, everyone. Very, very interesting talk.
Yeah.
Thank you.
Thank you. Bye.
Everyone. Thank you. Bye-bye.
Thank you. Bye-bye.
Bye.
Thank you.
Your hands.